Tiana Cardarelli, and I'm Program and Member Services Coordinator for the Catholic Principals Council of Ontario. And we are here to learn with you and with our guests today around supporting students and families who deal with autism. I turn it over to my colleague.
Hi everyone, so my name is Nadine Trépanier-Bisson. I'm the Director of Professional Learning at the Ontario Principals Council, and we've worked together, the three associations. So ADFO is hosting the French language webinar tomorrow, but we've worked with Stéphane and a group of principals on these three webinars. So this is the first in a series of three. We are recording these sessions and they will be made available by each association following that, along with a package, and you will receive that in an email following the webinar. That includes the whole package of everything that we've shared, including the PowerPoint presentation. The charts have been reproduced on a single page in case you want those for easy reference and easy printing. And at the end, we will also be posting into the chat room and include in the follow-up email a link to a survey to get us some feedback. There is the Q&A function if you want to ask a question. When you put a question in there, those are only seen by the presenters, and we can answer live or we can send you a response individually. At the same time, please, if you have any questions, use the chat line. We are planning for a 45-minute of talking time, if you will, and then some time at the end for 10-15 minutes of questions if you have them. So our guest today is Stéphane Beaune. Stéphane, I will let you introduce yourself as you get started, and just leaving it up to you to continue.
And Stéphane, just before you get started, just commentary. If you're not familiar with the Zoom platform, you'll find the chat and the Q&A either at the top of your screen or the bottom of your screen, depending on how your computer is configured. And please know that we'll have some polls during the course of today's webinar, and that's an opportunity for us to get to know you and for you to have voice in the learning. Thank you. I'll be turning off my camera at this point and handing things over to Stéphane. So Stéphane, thank you and welcome.
Thank you. Welcome everybody. It's my pleasure to be spending the next 45 minutes with all of you. I've been working in autism, the field of autism, for the last 25 years. I'm still involved a lot with a lot of the French and English board in Ontario, in Saskatchewan, and I do a lot of work in France also. So I also teach at Nipissing University the autism course. So it's really a great opportunity for me to be talking with all of you this afternoon, and hopefully it's going to help, especially because you're the leader, you're the front person that really needs to take some leadership, especially when it comes to autism. So hopefully what we talk about today will share some lights, and maybe we'll answer some question at the end. So what is the purpose today is really looking at what ASD is. It has changed a lot through the years. So the next few slides, I'm really going to focus more on how autism is a big part of our daily life when we work in the school system, but also how it's important for the leadership component, meaning all the vice principal and the principal. I've been coaching school principal and vice principal and superintendent now for the last 6-7 years, especially when it comes to self-regulation and autism. So it's really an opportunity for me to be talking with all of you. So this webinar really supports leadership practices and what type of knowledge we need with regards to autism. Like my colleague Luciana said, we also want to know who's participating today, so that's really important. And then there'll be a poll when it comes to today's seminar. So when we talk about autism, everybody now accepts that autism is neurodevelopmental disorder. I think we need to distinguish two elements, especially when we are in a position where we do IPRC, or when we're looking at evaluation coming from different professionals. You know, when we talk about neurodevelopmental disorder, it's just the maturation of the brain. That component is really neurological. people need to understand that every experience a child has will help, to create connection and then really focus on learning opportunities and all of that. When it comes to autism, why it's called a disorder, unfortunately, there's a process that's called the apoptosis, is where when each time a child is exposed to any stimulus or environment or activities, they will create learning opportunities. What has happened with autism, and that's why some of the key component when we're looking at, if you're involved in kindergarten, you need to really look at some of the key factors that are related to the neurodevelopmental perspective of it, is what are these kids showing. The head is often way bigger than the typical child. They'll often walk they'll tiptoe. They'll also really have a good rote memory. When it comes to working memory, it's really not really functional. So yes, autism is a neurodevelopmental disorder because there is components that are attached. Genetic plays a role. Why is it important for a school principal or vice principal to know that? Because you're going to be talking with these parents. And when we're talking about a neurodevelopmental disorder, we're also talking about immediate family that often will also have some component. So with regards to the broader autism phenotype, for example, often we see in research that mental health issues is often there on the mom side. Then we see there's also OCD, there's also bipolar disorder. So there is a lot of immediate family members that also contribute to what autism is. So it's not just a never mental, like the behavioral phenotype is the only thing we really know right now about autism. It's really important because the DSM-5, for example, are just the behaviors that are the endophenotype, meaning they are specific to autistic children. So it's really important because every child, depending on what happened with the brain development, will have a different profile. So you'll have early onset autism, for example. These are children that are born with already the autistic traits. So from the first few months of life, the parents will recognize that there's something not typical happening with their kids. If you get the late onset autism, for example, then you're talking about a child that seemed to have reached the milestone, but all of a sudden starts having language issues and all of that. So that creates a lot of social, emotional, and really the autistic trait starts to show. And then you have the late onset with regression. These are the kids that really had reached the milestone, and eventually in their life, they started to regress. So often they go back to wearing diapers, they lose language, they lose skills and all that. So that's all the part of the neurodevelopmental perspective. So if the brain doesn't eliminate the cells and the neurons that are functional, then that means the kid has lost the skills. That's why we work so hard with generalization. What's really then important for everybody to understand is when we talk about all the domains for a school system for learning. So when we talk about autism, we're talking about executive dysfunction. They have really hard time to take initiation. They have a hard time to really identify a problem and identify strategies and the action they'll take to reach that goal. The language, it's also often idiosyncratic. They'll show echolalia, immediate or delayed. Sensory motor is also with some kids, the more severe one often will have global sensory motor issues. Coordination, visual spatial skills, memory. People always say kids on the spectrum, they have an awesome memory. They have a rote memory. When we do evaluation, we realize that working memory is very dysfunctional within that population. So it's really important to, everybody likes to use the word neurodevelopmental, but it's really serious when it comes to autism because it affects all the structures within the brain. So when we do look at what are some of the main components that we've seen right now with the new DSM, I'll get to the level after, but we're looking really at communication, social skill, but especially restricted and repetitive behaviors. These were the domains that were least studied over the past. And now we're realizing that restrictive and repetitive behaviors are some key factors that will distinguish between a kid that will be, for example, labeled a level 1 versus a level 2 or a level 3. And when we look at, why is it so important? Why are we putting so much effort in autism? We're talking right now about 1 to 2% of the Canadian population that would be autistic. And then if we go specifically for Ontario, we're talking about 125,000 known. So these are people with that did receive the diagnosis. So when we look over the Canada, you can see that it's about 1 in 66. I'm sure it's going to change because I read something the other day that even with the new DSM-5, they thought that we would have a better stability and a better control over diagnosis, but there's more kids being diagnosed with autism, even with a change of the criteria and everything. So it's really serious. In the history of child psychopathology, autism is the pathology that has shown the highest rate of prevalence in the history. So it's really important that we look at it. And what's been hard on a lot of us that do work daily with that population is there was a lot of investment done in young kids for many, many years. If I look at the IBI, for example, in Ontario, it started about 20 years ago, were the first kids that were involved within the IBI. What happened after that is there was a big gap between the age of 14 up to 21. And when I, after working with, most of the school boards in Ontario, we realized that the population that received the least services were the kids that were in grade 7 and 8. And then when you look at comorbidity and the changes, hormonal change and everything, and isolation, we were starting to see a lot of kids being depressed, suicidal, and everything. So now we've seen the shift in Ontario for young adults and adults, but what we're seeing is we need a continuum of service, not just realizing that autism is a continuum. So that's where you guys all play such an important role, because being the leader of your school, it's also important that you understand how serious autism is, also how it is part of a genetic, environmental. There's a lot of studies being made now with the age of the parents. So for example, we were blaming mothers for years. Now we're seeing that older dads are also having a major impact on the diagnosis of autism. So there is more research, but we need to combine these research to bring better services when it comes to these children. So the prevalence, when we talk about male and female, right now what they're saying is 1 in 42 male will be diagnosed with ASD, and 1 in 165 when it's a girl. I think what we need to watch when it comes to gender, that's a new trend too. When we're talking about gender, keep in mind that the manifestation, the autistic traits are different between guys and girls. The boys are mostly external behaviors. If you do observation with young boys with autism, it's easier to see because it's really external. They'll bite, they'll spit, they'll scratch, they'll push, there's a lot of these behaviors that are there. And when we talk about social communication and language, often it's really key components with young boys. So they don't know how to express. They might speak, but they don't know how to communicate. So the emotional dysregulation that takes charge, then you see these kids having major meltdown. When we talk about young women that are diagnosed first of all, they're usually diagnosed 3 years later than boys. We're seeing now a trend where many women in their 30s are diagnosed with autism as compared to before they were diagnosed with either bipolar disorder or any other mental illness. Now we're seeing that these women all along were autistic. So the language is less of an issue. They're more naive, they're more introverted. So that means that often they go under the radar and we don't see them as being autistic as much as a young boy. But there's more, and that would explain also why the prevalence is higher, because before we thought it was mostly a male disorder, but now we're seeing more and more female being diagnosed with autism. And that's important because it does play a role when we talk about neurodevelopmental disorder, because there is a mutation in the chromosome. So when a male has Y and X, and then the mom has both, so sometimes one of them will be a carrier, so their child might be autistic, but they might not. And all the studies in twins have shown if there are identical twins, both of them will be autistic. If they're not, then one will be autistic. The other one for sure will have, 80% will have another diagnosis, either learning disabilities or something else. So when we look at the trend in education right now in Spec Ed, we're seeing that 85% of these kids are really receiving special ed. What we see also when we look at all the other students compared to the kids with special needs, the number of IPRC, 8% for the IPRC identified and not identified, 52%. Where it's becoming an issue, and it's having to work with a lot of my colleagues in the school system, it's really hard because now often we'll have non-identified with behavior, for example. But then we've seen a trend where for a while, we were seeing less kids with learning disability, but then these same kids ended up with an IPRC or an IEP for behavior issues. So it's the same thing with autism. I think there is some that are being, because they don't have the diagnosis, they would probably be under the category of either communication or behavior. So there is a high percentage of kids that end up in the special education needs that have more than one diagnosis, but often they're not identified with all of them, or there's just we need to still looking with eliminating other diagnoses to try to find one that's the main one. And that has been a major issue with autism. Imagine autism started to be a symptom, and all of a sudden now it's a disorder. And within that disorder, we've added multiple behaviors and multiple profiles and subgroup. So now when we really look at the prevalence, it's really hard to know who's a classic autistic child and who's a child with autistic traits. So that's why there is so much comorbidity, and that's why there's such a high percentage of kids that need a special education program. If you look at the demographics of it, the overview in elementary, there was of exceptional by the IPRC. You can still see that there is 8.5% non-identified. There's also quite a high number. Having worked within the school system for many, many years, and having really specialized in self-regulation and autism the last 10, 15 years, I realized there's a big percentage of kids entering the school system. More than 50% of kids entering kindergarten will have severe self-regulation issues. So that means the emotional, the social, and all of that. So that also in itself is really important to understand, because self-regulation is the key factor for a lot of diagnoses with ADHD, autism, Rett syndrome, severe anxiety disorder, and all of that. So any kid that comes in the system with self-regulation issues, for example, and autism is that, you'll see that they have difficulty with inhibition, they have difficulty with judgment, they have difficulty with playing with other children, socializing, and all of that. So a lot of these kids already then are showing a lot of these traits that are quite similar to what we know when we talk about autism. If you look at this graph, when you look at all the kids, the diagnosis within the system in 2017, 2018, there was 171,000. If you look at learning disability is up, if you look at the other population that's really on the rise, it's autism. It's already back then, it was already at more than 13%. And that's big. That's a lot of kids that are getting a full-blown diagnosis. Even with all the changes in the criteria, we're still getting, these numbers are rising year after year. And then you add autism with other comorbidity, then that would explain why we're also seeing higher rates. I think what people need to understand also is it's possible to have a child on the spectrum, even though they, we don't talk about Asperger anymore, but with learning disability, it's not rare that we see that. So contrary to when we talk about intellectual disability, often they will have autistic traits, because their primary diagnosis is intellectual disability with autistic traits. When we talk about neurodevelopmental disorder, Fragile X, it's a medical condition that bring, that unfortunately the child will also have intellectual disability, but also will fit with the behaviors of autism. So often they are within the system, especially the Ministry of Education, they will be identified as autistic. So it's becoming really hard to figure out when we talk about autism, and especially when we talk about placement, who are we referring to and what is the primary diagnosis? And I think this is something that all school principals and vice principal, you need to always ask the people that are providing either the evaluation or the people that are involved within the behavior component of it, is what is the primary diagnosis, and because that will have such an impact on placement, but also on the type of intervention that you will choose for your student. So one of the big difference that we've seen over the years, if you look on the right, the A, that was the DSM-4. Back then it was called PDD. And so you could have PDD and OS. That means the child didn't meet all the criteria because they were too young. And back then professionals didn't want to really risk, putting a diagnosis on. So then they were calling autism, and then we're referring to what we knew: social impairment, speech, communication, language delay. Restrictive and repetitive behaviors were there, but not really a key component. And back then, you could get some criteria. You didn't need all of them to get a diagnosis of autism. And that created a lot of issues because a lot of kids would have they would be borderline. And it really was hard because a lot of kids ended up in the IBI program. Some of them were PDD and OS. And so after an intensive intervention for a few months, a few years, they lost the diagnosis of autism because they didn't meet the entire criteria to start with. So then they were diagnosed with something else. So compared to, if you look at the DSM-5, we're talking more about a spectrum So the different level that we know, and we're looking a lot at the social communication domain and restricted and fixated interest that are really important to keep in mind. So just to give you an example, when we talk about restricted and fixated interest, if you look at somebody with OCD, they have rituals, they have certain fears, and every day they know they need to change and they have to work hard to get to it. When you talk about restricted interest and fixated interest, routine and everything needs to be the same. Resistance to change, insistence on sameness, is based on the fact that the child with autism, once they develop a sequence, a neurological, psychological, emotional sequence, they truly believe that that's the way it should be. So imagine when you try to change a sequence and try to work on something else, so they don't do pacing, so they don't do hand flapping, so they don't, because it's really important. For many years, people thought they need that. If they needed that, then it wouldn't be called a disorder. If do we say to somebody with OCD, oh, you don't need to keep on washing your hand 300 times a day, you need that? No, nobody would ever dare do that. So when it comes to restricted and a lot of these stereotypies, and we need to make sure that as soon as it invades with the learning opportunities, we need to replace them with more functional behaviors. So the DSM-5 the intention was really to bring into consideration all the disciplines that are important within the field of autism, and hoping that we would have clear criteria that would help us distinguish between somebody that's really autistic compared to somebody that might have autistic traits. So then when we talk about the spectrum, then that became a way to look at it, of rating the impairment. There's a lot of controversy when we talk about high functioning autism, because that does not exist in the criteria for a diagnosis. High functioning autism is not the same thing as Asperger's syndrome. A child with high functioning could be somebody that's able to socialize, that is able to accept and get involved socially, but have a lot of difficulty within the cognitive domain. Or you could have somebody that's really high functioning cognitively, but really low functioning when it comes to social emotional domain. So the high functioning component is not a synonym of Asperger. Asperger kids they reach the language milestones from the get-go. A child with high functioning autism could start talking later on and still be able to function. So just watch when people say that, because my first question to everybody that I work with, as soon as they say that, well, yeah, he's higher functioning, I will always ask, in which domain? Because kids that are born autistic, they have better outcome than kids that had late onset autism. So that means even though they could speak with the late onset, once the autism traits took over, all of a sudden these kids really have a hard time learning new skills and all of that. So somebody could say, well, a child that's born autistic is way more severe than a child that becomes autistic, that was, had a chance of predisposed to being autistic. So that's really important. When we look at the continuum, the risk with that is also, because if you look at intellectual disability, when you look at profile, for those of you that work with them, they have a flat profile. They have difficulties with all the domain. When you talk about autism, even though they have cognitive issues, sometimes difficulties, often they will have other domains like the visual, spatial processing. They might be good at that. So there is really some domains that they're strong, and there are really some domains where it's really weak.
Stefan, we have a question. I'm sorry.
Oh,
What does OS stand for?
On which slide?
PDD and OS was a term that
Yeah,
you
the pervasive developmental, not otherwise specified.
Great. So Joey, that would be NOS usually, and it stands for not otherwise specified. Thank you, Stefan.
Yeah, thanks for that's a great question. And that means it doesn't exist anymore. So now they have to really put a diagnosis on the child. So when we look at the continuum also, it's really important that when we look at the rating of impairment, you'll see how important the DSM is for school principal and vice principal, even though you might not think right now, but once I get to that component, you'll understand. But really, it's really clear that we look at, if you're a school principal, before making any decision, you really need to ask some key question. What is the profile of the child? What are some of the manifestation? Because a lot of the real developmental domain, are not even in the DSM. Joint attention, for example. Every child on this planet, at the age of 1, a typical child will learn to use words based on joint attention, the ability to share an object or share a stimuli with mom and dad, and then mom and dad will name what that stimuli is called. Then the child will have eye contact, look at the object, and then have eye contact with the parents, really to share and have the eye gaze. In autism, we don't have that. But we don't see that in the criteria for a diagnosis. These are key components. Eye gaze. Can the child follow, not eye contact, eye gaze? Can the child really follow when you're moving in a classroom and a teacher? Can he switch and then follow where the attention should be? If you don't follow the eye gaze, if you don't really learn joint attention, you will have what we call attentional lability, meaning you won't know when to engage or disengage from a stimuli. These are key components in autism that does not exist in any other disorder. But we tend to neglect that, and we tend to add other diagnoses like ADHD, when we know for a lot of kids on the spectrum, it's mostly the pivotal skills that are not there when they're young, so they don't know how to discriminate information. So if you don't know how to discriminate information, for example, you don't know, your working memory doesn't know which information to keep in mind, and use that to either do an activity, whatever you're asking out of them. So that's a child that has never learned. So if you don't have a good working memory, you won't know where to focus your attention. So there is a lot of misdiagnosis or comorbidity based on the fact that a lot of people don't understand some of the pivotal skills that these kids need to learn at a young age. So when we talk about, we did put some example of seizure. 30% of kids on the spectrum might develop seizure in the adolescent. Again, when you're talking about seizure, you'll talk maybe about intellectual disability, depending if it's the petit mal or the grand mal. Then that's also, you probably learned or read somewhere about the gut brain component about with autism. A lot of them will have issues with bowel syndrome, sleeping problem, inhibition. So it's really, these are the types of questions that if I was in charge, and because we need you, you're great leaders in your school, but you need to ask more than just the diagnosis, because you're only going to get the criteria that are in the DSM-5. You're not going to know if the child is able to play. Which level of play is he at? Is he just an observer? Is he just in object manipulation? Where is he in his development? And then build from that. Don't hesitate to ask questions that it's out of the, think outside the box, please. So the cool component of the DSM 5 is because finally they decided to talk about level of severity. So now we have 3 levels, level 1, level 2, and level 3. Requiring support in level 1, substantial in level 2, and very substantial in level 3. What's really important, because, and we see it now with what's happening with the sad situation with the virus, many families with a child with autism right now are at home not knowing what to do because their child is so dependent on the adults all the time. So they lack the independence, they lack the motivation, they lack the ability to take decision, they lack also the ability to make choices. Why? Because from the get-go, we always provide them with an adult, and that adult becomes the second brain for that child, and that means the child will be highly dependent on. So the level of severity in the DSM, if I want to make it, school friendly, ask yourself, how many kids are dependent? How many kids do really need an EA? And how many kids only need what we call guided practice? A level 2 for me, that's a child that's emerging. That's a child that has some skills, but requires some guidance with specific activities, with specific situation, but he should not get somebody that's 100%. The only kid right now that needs 100% would be a level 3. But because even within the intensive intervention, we've always created this one-on-one phenomenon, which really makes it hard for a child to transition into a school and all of a sudden being with other kids. So for me, level, don't look at it from a clinical perspective, look at it from a educational perspective. Which level is this kid at? How are you gonna, reinforce, help that child become independent, teach that child some skills so he's more independent, and also provide explicit teaching so that child is able to have a real inclusion and not just integration. So that's, for me, are very key for all leaders that need to be upfront with their teams, because often when we've tried it in multiple schools, we've taken the EA away from a child that was able to do stuff, but because they do everything, autistic kids do everything by association. If you're not there, that means they'll have a meltdown because there's a step missing in their sequence, meaning the adult either has to prompt, the adult has to do for them, the adult has to really guide the child all the time. So if that person is sick for a few days, then we're dealing with major meltdowns. So being autistic doesn't mean that everything, all the routine needs to be the same every day. A lot of these are just reinforcing the autistic traits. Ask yourself, when your staff, when your team, when you're doing observation in the classroom, when you look at what they've put in place, they're doing it for who? For the adults or for the kids? Strategies are supposed to be for the children. So if you only, recreate insistent on sameness, and then when you have changes, then that's normal. The child will have major meltdowns. Level 1, without support, they will have difficulty initiating social interaction. I would go even further than that, difficulty initiating cognitive task, because executive function, the child needs to be able to take initiation to be able to understand a task, to be able to discriminate information, to be able to think what strategies he or she will use and how they're going to use it. They'll plan and then they'll do it. There's a typical unsuccessful response to social overtures of others. They may appear to have decreased interest in social interaction, for sure, because we tend to teach them one skill at a time, and that's now how life is. After I've learned how to say hi, what's next? So these kids need to understand. So if you're going to teach them social skills, they should teach you should teach them a sequence of action. What do you want? What are the outcomes? What the objective? And then make sure that you teach each step one by one. Inflexibility of behaviors causes significant interference with functioning in one or more contexts. They can't generalize because they're often most 80% and even more, they're dependent on an adult to transition with them. They don't have difficulty transitioning, they have difficulty anticipating. The inability to anticipate cognitively is the issue with autism. It's not to move from one room to the other. It's not expecting, not knowing what's going to happen in between. And the same thing with switching with activities. Level 2, marked deficit in verbal, nonverbal, social communication skill. That goes back to what I was saying about teaching joint attention, teaching about, reading nonverbal facial expression. So if you don't know that, you don't know how to ask questions and you don't know how to respond. Difficulty coping with change. Again, because we've been feeding the autistic traits for so long, because we never thought that at one point in the history of autism that we would have a lot of kids with potential to graduate and have a typical life. So, and then restrictive, repetitive behaviors will interfere there, because level 2 would be more, they're conscious of their difference. So we will see an augmentation into the autistic traits. Level 3 is where really it's severe. We're talking more about kids that don't have, they're nonverbal, often not even echolalia, limited initiation, extreme difficulty with change, great distress, changing focus or action. They need to be redirected all the time. And then the restricted repetitive behavior are very strong and affects all aspects of their life, and often will have self-injurious behaviors that will kick in. I see question, I'll just go to... Okay, Jim asked, in terms of scheduling, how often and how much of the team should change with regards of generalization? You should change and you should build the routine with the kids right there every day, and try to change as much as possible. Add new things within the routine, add new people to initiate the routine. That's really important. Add, you can put blank spot within the routine, not knowing what might happen. So that's really important. Then Ken is asking, can you explain a bit more about the difference between difficulty to transition and inability to anticipate? Sure, with pleasure. So when we're talking about inability to anticipate, Ken, we're talking about the executive functioning. So the ability of a child to project in the future. So to be able to think either out loud or think, with the inner voice of, okay, I'm going to the gym. So I know that once I go to the gym, this is what I'm going to see. And then they're able to replay in their head what is going to happen. They might see people, they might, see different things happening. So they cognitively, they are able to imagine what the process is going to be at. When we're talking about difficulty to transition, it's just the inability to engage and disengage. Often kids on the spectrum, it takes them a while to engage into an activity. And once they start, they don't want to finish until, they don't want to stop until they finish the activity, or they don't want to, because it's highly motivating, they don't want to transition to another task. They don't want to transition to another room. They don't want to go back to their desk. And so the transitioning in that case is more related to the inability of a child to engage and disengage and follow the typical rhythm of a classroom. Compared to anticipate, that's a cognitive skill. So 70 to 80% of kids will also meet criteria for more or one or more other disorder. So as you see, these are all disorders that are associated with autism to a certain level. But again, I always say, if you look at autism and you look at ADHD, you need to make sure that the child really respond to the criteria of ADHD. Because, for example, when I just explained to Ken, a lot of kids on the spectrum, it's more of an issue when we talk about attention. It's more attentional ability. It's the inability to follow and shift cognitively, meaning engage and disengage. So once they're engaged, they don't want to disengage. So they have a really atypical profile when it comes to attention abilities. ADHD, the profile is the same. Even when they do fun things, they need to monitor. The reason I say that is because when we put kids on the spectrum on medication that they don't need, it really has negative impact. What we really see with autism that is really a consequence of is anxiety and depression. So a lot of these kids, they'll be anxious and they also will have bouts of depression. Some of them might also have OCD, but it's really rare. OCD is so specific to specific domains. So if they do, then okay. If they have phobia, then okay. But often it's more they have restricted interest and issues with that. The anxiety is often caused by more the inability to manage within an environment. So the position that sadly but true, the position that people have taken for many years, for example, is each time we saw a kid that gets anxious, we, rather than work on gradual exposure to that stimuli, that environment, we pull out the kid out of it. So then we're reinforcing the behaviors and the anxiety, because the kid gets the message that child is getting is, yeah, you should be anxious, even though there's nothing dangerous about what's happening. So it's really, and people need to also make sure when they talk about sensory, we're talking about the problem with modulation of sensory stimuli. So what happens when we talk about from a neurodevelopmental perspective is they have a dominance with one sense compared to the others. This is another chart where you see all the overlapping with behaviors. That's why as a health professional, we know we have mental health now in the system. We need to make sure that we respond to suicidal, depression, anxiety with a lot of these kids, just like with other children. So things to remember is what we see in the manifestation often is caused by something else. So just make sure you ask the right question. When we talk about learning, we should be referring to the type of pedagogy we're using. These kids respond better to explicit teaching. And me, that also do a lot of work with self-regulation with all kids. With all the schools that I'm involved in Ontario and Saskatchewan, and especially in France with the schools, we realize that, and Berkeley with ADHD realized the same thing. The more we work with explicit teaching and self-regulation, the more we can really hope for full inclusion of all the kids within our classroom, because a lot of the bad behaviors results from self-regulation issues, including with autism. So right now, we went from the expert model, this what we're promoting now, because we want you guys to be the leader with your team. We're talking more about interdisciplinary. So you need to do case studies. You need to have all the people around. The interdisciplinary approach is parents and child in the middle, and we built around them. And everybody has a role to play. Who does the observation? Who does the analysis of it? who does the implementation of the strategy, how much, who's going to do the coaching, who's involved, who's not, and what are the really the deadlines for meeting. So for me, for example, every 4 to 6 weeks with the families that I work with in the school system, we do a follow-up with them. So that helps us to work within the interdisciplinary component. You know, my hope is we get to the transdisciplinary where everybody's going to have a specific role. So the medical world will be part of the education world and vice versa, where all the expertise of everyone's going to be sitting around the same table, and not just through telesite, for example, but really we have people that are helping, and the voice of the teachers and the voice of the school personnel, the voice of the school principal are as valuable when we talk with the medical world as, because if not, then it becomes hard. We get the diagnosis, but we don't get the support. The impact on families, emotional, physical, financial. I did talk about the depression with moms. There's a lot of the phenotype there. So it's really important to keep in mind that some parents are also autistic. So when you get them in the RPRC, make sure that if you talk about socialization, you might get reaction because they don't have social life themselves in their daily life. So make sure that you understand that these kids have parents and they have an history of their own. And so to keep that into consideration. So the leadership and supporting it. So creating relationship, open communication, and a lot of modeling. So as a school principal, vice principal, you need to be the model for your team, just like then they will be the model for the teachers in class, and then they'll be the model for the kids. So final words, there'll be a quick polls and a survey, and then there's a glossary at the end of the PowerPoint. Thank you so much.
Thank you, Stefan. So as people are answering the polling questions, I would just like to reiterate in regard to the last point. So the glossary of terms as well as the list of all references will be in that PDF package that you will receive, as well as part of the PowerPoint. Any sources that we have and that we've been able to link, we've put the link there, the clickable link there, so you will have access to all of those resources as well. And I just want to say a huge thank you to Stefan. His expertise has been highly beneficial to us, to this team, and is obvious through his presentation of this webinar. And I wonder, Luciana, if you have a few final words.
Thank you, Nadine. I again want to thank everyone who was able to join us today. You should know that we were up to about 160 people in all told. I think that really speaks to the need for this kind of information. Stefan, thank you. The comments on the chat room are outstanding about the expertise, the way you presented the information, and how it is that you were able to tie this to the work of a school leader. So thank you to you, and thank you to each of our participants.
Thank you so much, and thanks everybody to take a few minutes today. And these are times, and I wish the best to all of you. Keep the great work because we all need you.
Thank you so much. Yes, please take care of yourself. Be well, stay well, and until we come together again, thank you.
Thank you.
Thank you.
Bye-bye.